All right, guys. So today we'll talk about atrial fibrillation management and pathophysiology. So AFib, irregular heartbeats. Uh, there are wavelets of electrical activity coming from the atria. These wavelets of electrical activity makes the electricity in the top two chambers, left and right atrium, uh, to be not in sync, and that will create fibrillation, which is, no squeeze of the blood, and that has, uh, important pathophysiological components. One of them is the fact that blood is not getting actually squeezed from the atria, and that can make it at higher chance of having clots forming in the atrium, mainly the left atrium. Hence, you need to be on blood thinners. And two, you have actually a lot of electrical activity going through the AV node, and that makes it more susceptible to have a rapid ventricular response. Number three, the fact that you're not really squeezing blood, you're losing about 20 to 25% of heart output because of the loss of the atrial kick. So the pathophysiology of the atrial fibrillation was really uh, not understood until 1998. A physician by name Hazigar, and this guy, he's a French guy, studied about 65 patients. He placed about 20 catheters in each patient. Each one of them has history of atrial fibrillation or paroxysmal atrial fibrillation. And he placed these catheters in multiple locations, studied them for about 24 hours. You imagine placing some catheters in some people for 24 hours. He did it in Bordeaux in France, and he found that about 80% of AFib coming from the pulmonary veins. So when the pulmonary veins connects with the left atrium, they connect in kind of this way, and that can create unstable electricity, and this unstable electricity can actually induce and promotes atrial fibrillation. So this is why we came in with the idea of pulmonary vein isolation, where you go from the groin up to the atria and try to isolate the pulmonary veins by using either heat, which is radio frequency, or cold, which is uh, the cryoballoon ablation. So when it comes to atrial fibrillation management, there are three things. Number one is controlling the stroke risk. Number two is rate. You have to control the rate. And number three, do you have to control the rhythm or leave patient in atrial fibrillation with controlled rate? So let's talk about blood thinners or anticoagulation. Each patient, you have to CHA2DS2-VASc score your patient when it comes to atrial fibrillation. So each patient has to have CHA2DS2-VASc score. And the CHA2DS2-VASc score is required and called standards of care. So you have to risk stratify your patient. Anything above 1, you have to put your patient on anticoagulation unless there is contraindication. And the anticoagulation, either Coumadin, warfarin, Eliquis, Savesa, Xarelto, or Pradaxa. So what I like is really Eliquis, because of the fact that it's safer and it's as effective as the other medications, but usually safer. Some patient population seems to be more effective. So this is the blood thinner, the anticoagulation aspect of it. Now, they say about valvular AFib versus no valvular AFib. The valvular AFib is when you have severe mitral valve stenosis or mechanical valve. So valvular AFib, mechanical valve, or severe mitral valve stenosis, in that case, you have to use Coumadin or warfarin. But anything else, you can use the newer blood thinners, which are the DOACs or NOACs. What we talk about, Xarelto, Savesa, Eliquis, and Pradaxa. The The patients who are not eligible for anticoagulation for whatever reason, history of bleeding, anemia, fall risk, dementia, can't take their medication. Medication is expensive. In that case, we can refer to Watchman device. Now, when it comes to patients at the nursing homes, I think you have to really weigh the risk versus the benefit. Hemoglobin is 8. Patient has atrial fibrillation, chest VAS score of 3 or 4 or less. In that case, probably not using anticoagulation. If chest VAS score higher, you probably need to use lower dose of Eliquis, 2.5 twice a day. You have to remember that Eliquis is renally cleared, so you have to use these 3 criteria when it comes to adjusting the dose, which is age above 80, creatinine above 1.6, or weight below 60. So if you have 2 of those or more, you can decrease the dose to 2.5 twice a day. Other than that, actually, you need to use full dose 5 milligram twice a day. If your patient is end-stage kidney disease, you have to treat it as creatinine of above 1.6, so it's one criterion. Okay, do you have any questions until now? So that's the anticoagulation aspect of atrial fibrillation management. Then the rate control this idea came from the affirm trial in 2002. They say that they found that, if you rate control your patient versus try to convert them to sinus rhythm, the outcome was the same. But that was before the era of ablation. It's really not valid as much, but still, it's not unreasonable. If somebody who's elderly, long-lasting atrial fibrillation has been having AFib for a long time, in that case, the rate control strategy is reasonable. So when I write my note, I say paroxysmal atrial fibrillation persistent based on the frequency and the how long this AFib lasts. And then I write chest VAS score and I write rate or rhythm control strategy. So the rate control strategy, somebody elderly, somebody is not functional that much, then rate control strategy with AV nodal blocking agents is reasonable. The medication we can use carvedilol. We can use calcium channel blockers such as verapamil or cardizem, or you can use beta blockers. You have to remember that if your ejection fraction below 50, you can't use verapamil or cardizem. That's actually contraindication. So, you probably best friend will be the beta blockers, which has metoprolol, carvedilol, Stalic, atenolol. Any of these medication is reasonable, and you can increase the dose until you get better control of the atrial fibrillation rate. The other medication, which is digoxin, I don't like really much. It's very kind of very toxic. It can gets accumulated in the body, especially in elderly people with chronic kidney disease. You have to check the level every once in a while, so you have to be very careful. You have to be careful about hypokalemia in the setting of digoxin use. So you have to check your creatinine, you have to check your potassium level. So I would not use it unless absolutely needed. Now the rhythm control, which is that what we use for younger patients. You can do ablation, or you can do medical management, or you can do ablation and medications. And medications, we have multiple medications such as flecainide, propafenone. You can't use this medication if you have structural heart disease, coronary heart disease, or decreased ejection fraction. So anybody with stenting or CAD or anything like that, you cannot use this medication. So for instance, sotalol you can use if you have somebody with coronary artery disease, normal ejection fraction, and amiodarone you can use for everybody. Sometimes if your patient has hypotension and you would like to control the heart rate, in that case, amiodarone is a reasonable option actually. You can use it for rate control, because of the beta blocking effect of amiodarone, and usually does not really affect the blood pressure unless you use it IV. So if you use amiodarone IV, usually affects blood pressure, but PO form does not really affect blood pressure. That's actually pretty much it. Now, if you have difficulties controlling the rate, then, pacemaker epidural ablation is a reasonable option. But that's last resort. You have question, guys?
Hey, Dr. Ibrahim,
Yes.
I got a quick question. So
Go
I've
ahead.
had several patients come in post-cabbage on a short-term amiodarone just to prevent AFib.
Yes.
So is that typically like 2 to 3 weeks,
A couple months, 2 months.
a couple months? Okay.
Yeah. I would keep them in
Okay.
amiodarone if they are post-op and for like 2 months, and that's actually the likelihood of having AFib after cabbage 30%, after valve surgery is about 50%, cabbage and valve surgery is about 80%. So it's pretty high. A lot of surgeons they use amiodarone actually before as a preventive measure to prevent atrial fibrillation or post-op atrial fibrillation. That's actually created from different mechanism, not the pulmonary veins. It comes from the fact that when you do open heart surgery, you open the pericardium, you create inflammation, and that inflammation actually can induce atrial fibrillation. And what I usually do, I wait for a couple months after the surgery, then I stop the amiodarone, I stop the blood thinner if they are on blood thinner because of the amiodarone, which is anticoagulation, like Eliquis or whatever. And then I'll get another heart monitor in about a month or so. And then if the heart monitor, why is 1 month? Because, amiodarone lasts between 4 to 6 weeks. So that's PO amiodarone. So we'll wait for 4 weeks, 6 weeks, get another heart monitor. If there's no recurrence of atrial fibrillation, then no need for anticoagulation. There's about 50% chance of having recurrence of AFib down the road, but you still have 50% chance of not having AFib down the road. So why you need to stay on anticoagulation? But you have to be careful whenever this patient comes to see you in the office to check EKG and tell them, hey, when you feel palpitations, let us know. Any more questions, guys?
I have a quick unrelated question.
Go ahead.
On statins, at what age do we stop statins, or do we stop
Yes, it
statins?
was studied recently, actually. It was studied recently. And, I kind of becoming, less aggressive above the age of 80, but it was actually studied that withdrawing statins in the age of 80 or above the age of 80 was associated with higher likelihood of having cardiovascular outcome, bad outcome, or cardiovascular incidents. So if your patient is wheelchair bound or bed bound above the age of 80 or severely demented, that's different from somebody who's still playing golf at the age of above the age of 80. But it was studied, and actually statins seems to be effective. The benefit outweighs the risk in this age group. It's also actually true for hypertensive management. So, letting blood pressure 170, 180 in this patient population was really associated with bad outcome too. So it seems like, you really need to treat them similar to what you do for your 60-year-old patient. Now you gotta individualize it. Again, somebody is severely demented, bedbound, there's really no way that their functional capacity gonna improve or their quality of life is gonna improve. In that case, you really treat, kind of urgent issues. But if somebody who's reasonably active, still able to hold conversation, come to your office, chat with you, in that case, you really need to be careful about controlling their blood pressure. And in this patient population, based on the GNC8 recommendations, which is a little bit different from the American Heart Association, American College of Cardiology recommendations, The American Heart Association want us to keep it below 140. The GNC 8 want us to keep it below 150. So I would say, you know, less than 150 is reasonable for these patients. What you don't want to do is to hammer him with a lot of medication. They are on diuretics and they are a little bit hypovolemic. They don't have much thirst feeling and bunch of vasodilators. All of a sudden, when they stand up, they fall, break their hip. Is disastrous. So you just need to individualize it and be careful and, you know, avoid too much blood pressure medications in this patient population. But still, as we stand right now, is you need to treat them similar to what you treat somebody else. She is a board certified cardiologist now. She doesn't have any questions. Any more questions, guys? All right. Okay. Let me know if you need any other topics, you know, right? We can chat about anything. Just, you know, bounce some ideas and you know, the field is changing fast, and every day, every week we have you know, new studies to guide us to better management and hope for better outcome for our patients. So I don't
Okay,
think.
one last question.
Go ahead.
So I read a study that said the LDL is supposed to be around 55 now. Is that correct?
Yeah, yeah. Actually,
Okay.
the rep was in my office today. So the Europeans have been doing it for a long time. In fact, I can tell you this, in 2006, I was even not a fellow, I was a resident in Houston. The guy by name James Willerson told me that if you can keep LDL below 50 like horses, you'll never have atherosclerosis. It was damn right. So back then, we recommendations were to keep it below 100, but we know that lower is better. So now, if you have high-risk patients, 55 or less is really the recommended one. But you know, nobody's gonna penalize you if you keep it below 70. You know, granted, you know, keeping it below 55 is extremely difficult. What I aim right now is to keep it below 70. But yes, you're right. Actually, there's consensus document in 2022 about November talking about high-risk individuals, coronary artery disease, that's for stenting, along with smoking, diabetes, peripheral vascular disease, history of ischemic stroke. All these patients, they will benefit from target below 55. And then you start with statin, you maximize your statin, then you go to PCSK9, which is Repatha, and the other ones, and then you go to Zetia as well. So Repatha and Zetia are, you know, kind of on the same level, but nothing can beat statins. All right.